Okay, good. Thank you. All right. So I was saying that the title of our lecture is Best Practices in 2025 for the Successful Appeal of Medicare Advantage Inpatient Post-Acute Denials. This presentation is reporting to you the end results of a 3-year period evidence-based practice study in which we developed a protocol. And as you listen to it today, you'll see that it provides a consistent approach, including strategies for overturning Medicare Advantage post-acute denials. As well, we do have some commercial plans that also had denials that we overturned, but the majority of them are Medicare Advantage. And when we went and overturned them, we saw 3 really positive outcomes. One was ensuring a patient's healthcare coverage rights were protected. We decreased length of stay, and we maximized hospital throughput. So the evidence-based protocol started in 2022 in the spring. So it was still the pandemic. And, listening to Kim and Greg, you heard about, at least, in New England, the amount of, backup and the great need for hospital beds. And this, implementing this project helped to, as one of the strategies to alleviate that. So there's 3 learner objectives. The first one is that we're going to be discussing the legal, ethical, and health disparity concerns of patients that are covered by Medicare Advantage plans and are receiving denials. And also, we chose from the CCMC, the Case Management Commission, principle number 2, which is the ethical principle that and that's how we prepared your ethical CEUs that you will be receiving if you complete your entire evaluation. And so that states, principle 2, that case management will respect the rights and inherent dignity of all of their clients. The second objective is to explain the benefits of overturning denials in your facility, including the 3 positive outcomes that we saw. And then also we give you a challenge to see if you could design a plan for how to implement this appeal evidence-based practice protocol in your own practice and in your own department. We have 2 disclaimers, and the first one is that we have no potential conflict of interest in the information that we're presenting to you today. The second disclaimer is that we have no relationship with any product either. So we started our evidence-based project 3 years ago, and it's been a long, rewarding journey. We faced many challenges. One of the biggest ones you heard this morning from our speakers, in the fact that the Medicare Advantage plans, as well as other commercial payers, are always in the mode of changing their requirements, particularly for appealing denials. And over the last years, where we've had so many political changes, administrative changes, and different, goals of each president, then we also had to deal with that. So that's some of the challenges we face. But in the end, you'll see when you hear our protocol that it resulted in significant positive outcomes as it improved the care as much as we could for our patients and families. So the motivating factor for starting our project was this case study. And this case study is really a great teaching tool. I'm going to cover some of the key issues, but it can actually be used for appealing denials because of the many strategies that we use throughout affecting the ultimate transfer of this patient. So the patient that we were dealing with was one that was seriously chronically ill. She was from out of state, and she did gain insurance pre-admission authorization for a hospital stay in our state. And the way that she was able to do that is that she could actually prove that the care she needed was not available in her state. And that's actually a common strategy that you can use in your own practice if it's appropriate with the cases that you're managing. So prior to the admission, her husband had used an insurance broker to purchase what he was told was the best insurance for his wife's complex condition. It was an MA plan. And, since we started this, because this was the first case, this is the case that motivated us to start the project. And so we were learning. I had a strong background in I brought that to the case, but we were learning all along. And so what we've learned since this is that the insurance brokers that guide American citizens to choose insurance plans can actually be employed by some of our larger insurance companies. They could be commercial, they could be MA, they could be both. In addition, the insurance brokers get commissions directing patients to the insurance companies that support them. So that's just something really to know about when advising our patients. So after 30 days in an ICU, trach invented, the patient's physician felt that the patient was ready for an LTAC stay. And an LTAC, just reminding you, is a long-term acute care hospital stay. It is the highest level of rehab. I believe that it was, the definition from it was discussed today. It's also, for payers, it's also the most expensive one. Sorry, my slides are moving themselves. Okay, so the doctor, the physician in charge of the case, wrote a discharge order. The patient was referred to the LTAC, and the LTAC accepted the patient. So what does that tell you? Number one, the physician over the case felt that the patient's medical needs were met by a transfer to an LTAC. And then that the LTAC accepted meant that the patient met the criteria. But what happened is the MA plan denied the transfer. So one thing to just review really quickly is, one of the big initiatives that happened starting in 2023 into 2024 is particularly resulted in the final rule for 2024, had a lot of rules and regulations directed at MA plans. I'm going to talk about it in a little bit, but one of the impetuses for doing that is, for the first time in history, 51% of the American population eligible for Medicare were enrolled in MA plans. So the current administration at that time, 2024, they had been receiving complaints and concerns from the public that the MA plans were not meeting their medical needs and the high rate of denial. And so in the final rule, it clarifies that the MA plans have to be compliant to the rules and regulations set for traditional Medicare. And what that means is that the MA plans cannot treat their beneficiaries different, deny them the rights that are offered to traditional Medicare. And one of them, of course, is the need to obtain a pre-authorization to receive care at a post-acute facility. So just having that in mind, because we knew that rule was part of traditional Medicare. We knew that that was the way that the MA plans were supposed to react even before the final rule, because the rules for traditional Medicare go back to the 1960s. So we all knew that, and we tried to hold the MA plan accountable to that. But instead, what they did is they offered the husband, who was totally dedicated to that patient and wanted her well and wanted her to be discharged back to their home state. But the physician had told him that the only option that his wife had was to have an LTAC stay so that she could reach her full level of reconditioning and free and full level of rehabilitation. And so the husband was offered to appeal it. And even though he was working with the case manager, we hadn't started the protocol yet. So he went ahead and appealed and lost. And then the MA plan told him that was it. There were no other options. There was no other alternatives. Nothing was available to that husband. And what his feelings was, what he communicated to the case manager was exactly what we see in the literature. And that is that the husband felt distraught. He felt hopeless. He felt desperate. How would he get the care for his wife? And he turned even greater to the case manager to help him navigate. Now, the case manager had a discharge plan. Case manager attended rounds every day. Case manager knew that, the medical plan per the team, the medical team, also knew what the demands were within our hospital with our ED on code gray every single, or code help every single day. And so she had her plan. But unfortunately, because of the denial, she could see no alternative. She could not see the path going forward. So she contacted the educator for advice. And the educator, when listening to the case manager, could hear that all the best practice standards established by CMSA were being upheld by this case manager. And like what the educator heard was advocacy, ethical principles, the highest standards of practice, and then also articulated principle number 2, which is the ethical principle that we're using to convey this case study and this lecture, to respect the dignity and inherent rights of the client. And so case manager and educator went to work, and we tried every single strategy we could, day after day after day. Now, while we were doing that, the husband, who couldn't sit back, he went and reported this case to the Department of Insurance in both states, Department of Insurance in the state the patient was in, and the home state of the patient. And then in addition, in his own state, one of his family members personally knew the attorney general and reported that case. Now, reporting the case won't usually help you. What we learned in the immediate period doesn't help you, but it will help you in the long term, because you're alerting the government that the MA plan is non-compliant. Also, special interest groups, you can go to them. So eventually they catch up, and they may do initiatives that in the whole picture will be an intervention. So we kind of learned about that. We've tried that and used that throughout our project, but we learned that it's really gonna change the bigger picture and not the case at that time. And so eventually what we turned to, and the end result, and what got that patient transferred, is that we called Medicare. Now, I know that everything in the literature and everything that CMS publishes says that a patient in traditional Medicare that wants to switch from an MA plan to, I'm sorry, let's do this again. An MA plan patient who wants to switch to traditional Medicare cannot do that unless it's in the enrollment period. But I want to tell you that we have done it in the 3 years. We have done this, not a large amount, but when appropriate and compliantly. And I've spoke to my colleagues who do and they too have done it. So Dr. Hershey talks about that, the rules and regulations, we know that they're laws, but they're gray. And sometimes you can move things that you didn't know you could do. You have a suspect, something in your gut. And so one of the parts of our project initiative is that any idea was a good idea and we acted on it. So when we spoke to Medicare, it was out of the enrollment period, and we told them the situation. What the representative on the phone said, the CMS Medicare representative said to us is, well, the patient in the MA plan is enrolled in Medicare and therefore can switch. And we switched just like that. So what had to happen is, just like any time a Medicare patient switches from one to the other, it had to be the patient or the husband representative calling Medicare themselves, requesting the switch. And then the switch happens, just like in the literature, on the first day of the next month. So everything in line, and Joanne will give you more of the details that, that we operationalized in that case. So the outcome of all our work is that this appeal protocol emerged. We started with one case in the spring of 2022, and now we've finished in the fall of 2024, and we've appealed 83 patients. Joanne's going to give you the details. And by doing that, we established this successful group of interventions that can overcome barriers. And when they don't, we move to something called a strategic initiative, which Joanne will explain. So you can hear in my voice and see the work we've done that we are very pro appeal. And these are the four reasons, really quickly, why we promote appealing and reach out to you and give you the same challenges. One is because in the case management standards, which I'll review with you really quickly, there is the case manager's role to promote advocacy and participation in appeals. Plus, we have rules and regulations. Dr. Hirsch went over that. And that is through the conditions of participation that we need to have a safe discharge plan. And also currently in the new updated regs that the patient and family need to be included. And so that we are fulfilling their goals too. The other thing is that healthcare is a patient right. And one of the roles of case managers are to maximize a patient's healthcare benefits. One of the last is that CMS states that traditional or original Medicare, so that's the original form of Medicare, we're going to call it traditional in this lecture. And the Medicare Advantage patient must be treated the same. But unfortunately, there are limited guardrails to enforce this through the Medicare Advantage plans. And so that needs to be done, because if not, there's healthcare equity that's existing between the two plans, all covered under being enrolled in Medicare. But the thing is that there are different rules and regulations, and that is non-compliant. The MA plans deny care. Traditional Medicare patients don't have care denied. They have payment rules to follow, but when a patient is being discharged from the hospital and needs to be appropriately to a post-acute facility with traditional Medicare, they just move if they meet the criteria and have a discharge order. That's what the final rule of 2024 states. And then the other thing to know is that of all the denials we're going to learn about that the MA and commercial payers are imposing on patients and families, that hospitals, nurses are only appealing 10%. We'll talk about that. That needs to be thought about. So let's go to the first reason that you should deny. You should appeal your denials. And that is the standards of practice for case management. And with the standards that come out of CMSA, it states that when there's a conflict, that the needs of the clients need to take a priority over other considerations. And we already talked about the ethical position that we're supporting for this lecture. And then, besides CMSA, the American Association of Case Management, ACMA, goes a couple of steps further. So if you combine them both for the very best practice, it states that proactive prevention of medical necessity denials is part of our role. Not only is it part of our role, but also that we are to support denials, perhaps being involved in appeals ourselves. If it is a family denial, we are to provide the information. That's according to the standards, if they're accepted by you and your department and your facility. And then also to utilize a process, and we're giving you one, to escalate and resolve a denial to secure payment for the necessary care and services provided to the patient. Because when a patient isn't compliantly covered by their insurance, often the costs are passed to the patient. Also, I mentioned already that we're held to the rules and regulations, such as the conditions of participation. And Dr. Hirsch already went over these, and that we need to provide an effective discharge planning process that focuses on the patient's goals and treatment, and that we also need to promote a safe discharge, and that not only meets the patient's care needs, but also prevents hospital readmission. So this part of CMS is asking us to be compliant to preventing readmissions. The next reason we want to appeal is because healthcare is a right, and we're helping the patient to maximally access their insurance. The right to healthcare is recognized in the Universal Declaration of Human Rights and the World Health Organization, both established in 1948 and still upheld today. For U.S. healthcare rights, if a patient can appropriately access healthcare, usually held under that is Medicare, Medicaid, and CHIP, which is the Children's Healthcare Program. And these are regularly navigated by case managers, especially at establishing discharge. Now, one of the things I just want to establish really quickly is that Medicare is not a sorry, is not an entitlement. It's not an entitlement. And all up until this year, when I would look at what were the entitlements that U.S. citizens were able to access, it always said that the only entitlement really is Medicaid and CHIP. Medicare is not an entitlement, and I'm going to explain to you why. But because of AI, and we have to watch out for AI, we're already being warned, it's not always correct. And so case management, within our role, we need to do that double check. So to reach eligibility for Medicare, one of the first rules of eligibility is that the individual would have to have worked 40 work quarters for 10 years. And doing that during that time period, that individual is paying FICA, the Federal Insurance Contribution Act tax. And you know about this tax because when you get your payroll check, either every week, every 2 weeks, every month, whenever you're paid, you see those deductions. And in 2025, we're going to have 1.5% of our taxes contributing to Medicare. And on an average, American citizens who are working are paying approximately 1.45% of your earnings to FICA, which pays for Medicare and Social Security. So it's not an entitlement because you're paying it. Also, in the literature, the average payment that a American citizen makes in their lifetime is approximately $100,000, which is kind of like, since it's paying to Medicare, is almost like a retirement plan that the government is holding for us, paying for our Medicare, paying for our Social Security. And if you work longer, which we're all doing, and you get a higher pay, you're paying more. So when traditional Medicare started in 1965 by President Lyndon Johnson, it established the basic rights of the Medicare patient, because it was only traditional Medicare then. And in 1977, President Clinton started Medicare Advantage plans, which invited the commercial payers or large commercial payers to contract with Medicare, to contract with CMS to cover the Medicare beneficiary. And when they did, they each have their own contracts. But when they did, the rules and regs were established. The ones I went, which I covered, is that the beneficiaries, Medicare, traditional Medicare, and Medicare Advantage have to be treated the same. And then also that when a patient moves from the post-acute setting to a facility, that there really shouldn't be a pre-auth, that the Medicare Advantage plan should support it, just like traditional Medicare. And at the end of your slides are your references. And if you haven't looked at this before, the frequently asked questions, the FAQs for the Medicare Advantage Plan Final Rule 2024, there's a question, and it says, can Medicare Advantage plans denied a post-acute discharge to a facility? And you know what? The answer is pretty clear. Government's usually not clear, but it says right there, no, cannot. And then it goes on to ask for the doctor's order and for the fact that the patient meets the criteria. And I already went over with you that in 2024, for the first time, there were more patients enrolled in Medicare Advantage than ever before in history. And it rose to 51% from 47% in prior years. And that's why I believe that the final rule for 2024 was established. Now, as Dr. Hirsch was talking, we don't know, what's going to be upheld and what's going to be overturned. So it's such a time of uncertainty. But I want you to know that the Medicare Advantage denials have increased, not decreased, but increased to 56% in 2023. Even the commercial plans, their denials have increased. And when I talk to colleagues and we talk about denials and we talk about appeals, we talk about facing the burdens, the increasing burdens that MA plans and commercials put in front of us, ever changing. And so we see that the challenges that are before us. And the other thing I want you to know is that MA plans are well paid for ensuring a Medicare beneficiary. In 2023, the government paid $462 billion to Medicare Advantage plans, which is 45% of the total budgeted Medicare spending. And this is an increase of 20 from 29% in 2017 to 45% of our Medicare budget. Now, I'm not going to spend a lot of time reading these or going over this because I kind of already have. And so what's important to extrapolate from the slide is that a low appeal rate, because hospitals and case managers are only appealing denials at a very low rate, presently around 10%. And that's a slight increase from 2019 at 7.5%. And when they appeal at 10%, the overturn rate is close to 80%. So think about this 1 minute. Only appealing 10%, overturning 80. Why isn't appealing happening? And the reason CMS wrote these two slides just were printed in February of 2024 and came from CMS. So why aren't they appealing? And one is because of the burden. And the fear is that the burden is so high that healthcare providers will figure out what's creating the denial and they'll stop providing the best care. That's what the problem is. And not only are patients and families frustrated, but so are case manager. It's tough. And when Kim and Greg were talking, they talked about trying to reach a case manager. Years ago, I noticed that all of a sudden it was rather than take me what I knew from my experiences, 4 hours to reach an insurance company case manager, that it was taking 4 days. And I thought, God, is this just me? Did I lose my skill? And then I started asking my colleagues, and across the board, across the nation, they told me that they were experiencing the same thing. So one of the strategies that the payers have turned to is pushing family appeals, giving less options for appeal, like decreasing the availability of the physician-to-physician appeal, and also making the expedited appeal, the straight appeal, harder to reach. And Joanne will go over that. And so now families are being invited to appeal, and it's so complicated for us who have medical knowledge, even harder for family members. And so for years, Joanne and I have been trying to find what is the percent that family appeals are overturned. Now, we already know that 10% of appeals that providers and hospitals appeal is close to 80%. But the thing is, for families, we couldn't find 56%. I just found it. So this information I already went over, and this is from the Office of the Inspector General. It was years ago, but they still say the same thing, is that the burden for appeals is rather high and can discourage and maybe influence caregivers. Lately, one of the things that the providers in our area have offered, but you have to ask for it, is an expedited fast family appeal. And this is the limitations to that. And pretty much we've covered that, but take a peek back at that. You might ask now, why do the insurance companies deny? And the only answer I could come up with, and you can put it in the chat if you know something different, like if you do work for the payer, we're really interested, but the only thing we could come up is financial, because the Medicare payment is by a DRG. It's a flat rate. So if the patient stays 3 days, or if they stay 30 minutes, I'm sorry, 30 minutes, 30 days, if they say 3 days or 30 days, that's the payment. And that's for the hospital. And that's what the MA plans are paying, and that's what Medicare pays the hospital. But when the patient accesses another level of care, the post-acute care, then the MA will have to pay again. It's additional charges to them. And it's estimated on top of it. Not only are they paid a monthly rate for taking care of the Medicare beneficiary, but there's also been lawsuits that basically say that there's there's some error in MA plan and commercial plan billing. And this one lawsuit, which was held in 2023, found a 90% error rate when AI was used. So you need to know that what some of the payers are doing, because AI can review a case in 1.2 seconds. It's not proven they know medical necessity. So they could do massive amounts of denials, and the medical necessity may have been met. So it's really prudent of you to appeal. And on that, sorry for the length, I'm turning over to Joanne. And Joanne, you can go into some of the question period.
Okay, June, you're going to have to...
Yeah, I'm doing it. Up to share. Sorry. Are you good now?
You stopped the slide deck.
Yeah.
Okay.
Can you just go back, June, or else, Maureen, can you start at number 29?
Okay, hold on 1 minute.
Thank you.
Did I stop my share?
No, you stopped the share. Let me pull this up.
Thanks, Maureen. Thanks for joining us today, everyone. We're really happy that you're listening to what we have to say.
I'm sorry, it's taking me a second. Look at it. Is that the slide, Joanne?
Number 29, I think. Next, hang on.
The next one?
I can do it from now. That's fine.
Yep, okay, perfect.
Okay, so these are the appeals we appealed on. We did 83 in total. 16 we overturned after a peer-to-peer call alone, but that meant we had to do 67 expedited provider appeals. We were able to overturn 49 of those, but for 18 we were not able to. And we came up with what we called a strategic intervention for a safe discharge. Of the 83 total appeals, 57 were on Medicare Advantage patients, and their results were that we had success with 7 peer-to-peer calls. We did 50 expedited provider appeals on the Medicare Advantage patients. We were able to overturn 38 of those, and we needed to do 12 strategic interventions for those patients, and I'll talk more about that in a minute. So of the total 83 patients, after the peer-to-peer calls, we were able to move 16 patients, and 6 went to LTAC, 3 went to the acute level, and 7 went to a skilled nursing facility. After the expedited provider appeals, we moved 49 patients in total. Just to show you that it wasn't always to a skilled nursing facility. 14 went to LTAC, 10 of those were Medicare Advantage, 14 to acute level, 11 of those were Medicare Advantage, and 21 patients went to a SNF. So when we talked about strategic interventions, what we were doing with patients were, we couldn't just discharge them to a level of care that was not safe for them, or they would just bounce back. So we would keep them in-house until they were safe to go to a lower level of care, or we would beg our therapy departments to increase the therapy they were able to give them in-house. And of course, they're always strapped for time as well. So it's a big ask to ask them to intervene more on the patients. And then we'd send them home with services. Or occasionally, as June was saying, we encourage families to change the insurance back to traditional Medicare with a secondary insurance to take effect the first day of the next month. So I looked at the length of stay from when the patient was ready for rehab and a bed had been offered, and I looked at the extra days that they stayed in with us. After a peer-to-peer call, the average was 3.6 days. It was increased for the expedited provider appeal. It was an average of 7.6 days. And for the strategic interventions, it was quite a lot more. It was 18.2 days. But sometimes that was in the case of, I think we had 3 patients who decompensated and ended up staying with us and unfortunately passing away. So that really extended the length of time they stayed with us. For the Medicare Advantage patients alone, the 57 patients. So they're ready for rehab. If they had traditional Medicare, all of these extra nights could have been avoided. So for LTAC, I took out the patients who stayed for strategic interventions, but they stayed 8.7 days, an average of 8.7 days waiting to get to LTAC. For acute level, they stayed an average of 6.6 days. And for SNF level, they stayed 5.8 days just waiting, and it just avoidable nights, avoidable days. And then I looked at the data for when the final rule came in January 2024 to see if maybe that made a difference. I took out, again, the patients who we need to do a strategic intervention on. And what it showed was that for patients going to LTAC, they actually stayed a shorter time. Acute was about the same. But for patients going to SNF, the length of stay actually increased for them after the introduction of the final rule. So I'm not really sure how to explain that. The numbers are small, obviously, and they're not statistically significant. So just very briefly, you all know this, the process at the moment for us for the post-acute appeal process is that the rehab facility submits for authorization. And I know that some facilities are working on changing that, but this is our process at the moment. And that authorization either gets approved or denied. If it's denied, you should get a peer-to-peer call opportunity. And after that, the decision is either an overturn or it's still denied. And then your options are to do a standard or formal appeal with a 60-day turnaround time, or an expedited provider appeal with a 72-hour turnaround time, or a family fast appeal. And then these are the outcomes after that. So just briefly, these are the steps that we came up for our evidence-based practice protocol. The first, be proactive, anticipate the risk of denial. Identify that the insurance company appeals process changes and anticipate their changes. Concentrate on working on your peer-to-peer practices. Request an expedited appeal when it's so important to appeal for these patients. Writing a cover letter on what to put in it, incorporating the government rules, planning on coverage during the appeal time, the 72 hours. And just in case your appeal is not approved, what will your strategic intervention be for this patient? So these are our steps to the peer-to-peer calls. And each of these steps we came up with because something happened. They threw a barrier at us and we had to figure out a workaround. And each time we learned, every time there was a problem. So the first step, be proactive. On admission, look at the patient's insurance and anticipate the patient's discharge needs. If the authorization is denied, be committed to the appeal process, be determined to overturn the denial, and be passionate in the pursuit of the outcome. You may have to reach out to your financial department to verify the insurances are listed correctly, because occasionally it is not. So make sure you've got the primary correct. And anticipate a need for a peer-to-peer appeal and the potential need for an expedited provider appeal. Step 2, be vigilant. Once the facility has gone for authorization, be vigilant for the need to do a peer-to-peer call. So in our experience, the rehab facility gets notified by the payer with critical information and may not promptly let you know. Keep asking them every day if they have heard anything and make sure that they have your contact details. There can be an unrealistic deadline set by the payer for the peer-to-peer call. Sometimes it's a 3-hour window, and that gets overlooked during a busy day. And some payers are not open over the weekend. We've been told on a Friday, oh, you can do a peer-to-peer call on Monday. So the patient sits there for another 3 days. Even after the call, some payers claim they need up to 72 hours to make a decision on whether the peer-to-peer call was successful. Step 3, choose the right clinician to do the call. Ask someone on the team that you know has a positive overturn track record, who is also familiar with the patient. Make sure they willingly agree to participate, and avoid using those who are reluctant to make the call. If the clinician is not confident going into the call, it may not be successful. It's difficult. Clinicians are rounding on their patients in the morning or they're in clinic, and it's really hard to get them with a time period to make the call. It's very frustrating. I had one this week where it was a brand new attending, first day with the patient in the ICU. He had a half-hour window, but when I rang the insurance payer, they said, no, we need a 4-hour window and we'll let you know. It's just so hard in an ICU to do a peer-to-peer call. So watch out for clinicians that say things like, oh, I never win these things, or I don't want to say something that's discoverable in court. Or once the payer said to me, your doctor didn't really seem to want to talk about his patient. So really choose your clinician wisely. Then focus on the medical necessity of why this patient needs rehab. Don't deviate. Stay focused on the patient's medical needs. Don't start getting into the social details of why the patient can't go home. This is not the time to express personal opinions about the authorization process or the insurance industry. The peer-to-peer call is very brief, so offending or attacking the doctor representing the payer will not help overturn the denial. So educate the clinician. I had one yesterday. I used email and phone, and then I went and met with the physician. It was his second peer-to-peer call ever, which was a little bit of a red flag to me. But I also printed out a brief summary of levels of care for the clinician. And I kept saying to him, be confident, you can do this. And he looked very doubtful, but he did win. And he got the patient to LTAC. So I think he felt a bit empowered at the end of it. So even the most experienced clinician is unaware of the rehab levels and requirements. I had a very experienced surgeon, even older than me, after a family meeting about 6 weeks, say to me, wow, I learned something just there. I didn't know there were 3 levels of rehab. So don't assume that they understand what the levels of rehab are. And this is just a very brief thing that I made up just to give to people in emails, or I printed it out for the attending this week. Step 6, be persistent. The P2P is the first step in the appeal process, but if it's not offered, you should request it. State that it is a patient's appeal right, especially if it's a Medicare Advantage plan, and persist. If the payer continues to decline this appeal option, they may change their decision and offer a peer-to-peer opportunity. We did have that happen to us once. We kept saying day after day after day, and after a week, they finally let us have one. We strongly recommend participating in the P2P call if you're given the opportunity. If the denial is overturned, an immediate authorization for post-acute discharge is provided. So do not skip it if it is offered. And if you can overturn the denial at this stage, it will reduce the length of stay. Step 7, act fast. Don't give up. If your denial is not overturned, move quickly. Call the payer as soon as possible. Notify them that you are going to file an expedited provider appeal. This year especially, I've noticed that they are not offering it to people, so you have to tell them you are doing it. So ask for the phone number and the fax number of their appeals department, and try to get the appeal faxed that day if possible, because every day that the patient sits there is just extra length of stay. And if you can see that the PTOT evaluations had not been done in the previous 48 hours, I would order them, because in my experience, they will call the next day and say, oh no, we need updated evaluations. These are too old, even though you've been sitting there for 4 days waiting for them to come to a decision. All right, so this is my favorite picture, the dog with the bone. That's how it feels when you're filing an expedited provider appeal. You just have to sit there and not let anyone stop you. You have to really be relentless and persevere for this patient. Step 1, write a cover letter. You're going to send clinical notes, but I feel like the cover letter is the most important thing. This is your chance to plead for the patient. So you also include the facility you're calling from, the facility you're sending the patient to, the provider you're representing, and the level of rehab you're asking for. At the top of the letter, you write in big, bold letters, expedited provider appeal. If you do not specify that, the appeal will be processed as a standard appeal with a 60-day turnaround. So put the NPIs of the provider and your facility, the patient's date of birth, and the insurance ID. Avoid any reason for this appeal to stall. They will call you and verify things or ask for things. So give them as much information up front as you can. Oh, and they always call after hours or on the weekend to get this information. So step 3, what should the cover letter say? Make it concise and personalize it to your patient. Do not just copy and paste from the notes. Do not use nursing shorthand, and avoid acronyms and initials. That's for you, Dr. Hirsch, and abbreviations. Be very clear about the level of care you're appealing for. Justify the level of care requested. Why does the patient need that level, and why can't their needs be met at a lower level? So you've got to keep it brief to keep their attention. The rationale about the acronyms is that I don't understand all these medical acronyms all the time, especially if it's not a specialty I'm familiar with. So don't assume that the person on the other end of the fax knows what you're talking about or even has your level of medical knowledge. The first representative that you are reaching is compiling a brief report for their doctor. And this is your most important chance to rationalize the correct level of rehab for the patient. So we started putting in paragraphs, depending on the insurance, if it was a commercial plan or a Medicare Advantage plan, we cut and pasted different paragraphs. So have a template ready and use paragraphs. Just copy and paste them into your template when you know what kind of insurance your patient has. And these are some examples. You can come up with different ones, but. And then choose your clinical notes wisely. Depending on the payer, you may be asked to provide an appointment of representative form, the AOR form, and that is CMS 1696. It is in English and Spanish variations. Fax it at the very front of the notes after the cover letter, because they will always call you and say, I don't see the AOR, and you can say, oh, it's after the cover letter. Yep, so it is. Send a PM&R note if you have one. The physical medicine and rehabilitation specialists, this is their thing. So if they can if you can send a note that supports the level of care that you're asking for, that's golden. That's fantastic. And I started poaching one of our PM&R specialists' comments and putting it into the cover letter. And she writes, provision of services in a less intensive environment risks significant complications and a more limited functional outcome. But only send relevant supporting notes. If you have notes that say patient could go home, patient CMO, don't send those. And then I list the notes in the order that I'm faxing them to be the most impactful. And then you have to follow up. You have to call the payer and confirm that they received the fax, because in my experience, they sometimes have given you the wrong fax number. They'll say, oh, that's for a different plan. You need this one. And try to get a confirmation number for all the conversations that you have with the payer. I learned that lesson the hard way after going back and forwards with one of the payers a couple of times. Everything gets wiped from their system. And even after talking to them for a week or something. So I'm getting better at it now, but write down the confirmation number of every conversation. And then you have to be accessible, because as I said, they will call you after hours and on a weekend, usually a Friday at around 6:15 p.m. or Saturday, 11:30, I'm at Costco getting a call saying that they overturned the denial. So the provider appeal has a 72-hour turnaround for a decision, and that is regardless of whether it's over a weekend or not. So keep in mind that if you submit on a Wednesday, the result is due by Saturday. Likewise, Thursday, Sunday, Friday, and Monday. So consider giving your cell phone as the contact number. This is what I do. If there is not a consistent person to take the calls for the next 72 hours, your appeal can be denied. One overturned decision was left on my desk phone at 6:30 on a Friday night. I just happened to log on a Saturday morning and find the message. But if I hadn't, the patient would have still been sitting there on the Monday and I would not have known that the appeal had been overturned. One of the largest companies reads you a disclaimer when you submit an appeal that says, if you are submitting on a Friday or over the weekend and are not available for follow-up questions or documentation, this appeal will be denied. So since the final rule at the beginning of 2024, the process has felt more aggressive to me. One person said to me, this Medicare Advantage plan does not offer a peer-to-peer call opportunity, which of course is false. And each time last year, 2024, the payers offered a family fast appeal without mentioning that the provider can do an appeal. So why would they be promoting a family fast appeal and not a provider appeal? And also, when I started quoting the final rule in the cover letter, appeals immediately got sent to a third-party reviewer instead of having their MD review it. So be aware, things change all the time. It feels as if the more successful you get, then they change the playing field. For the first few months, we thought we were doing really well. We had a 100% success rate, but then things changed and we had to come up with new plans. I just want to really briefly go over 3 case studies if we have time. First one is a lady with a Medicare Advantage plan. This was in 2024 after the final rule. 65-year-old lady with encephalopathy and epilepsy, denied for the acute level of rehab. We were notified of the peer-to-peer opportunity at 4 p.m. in the electronic system. However, the message was missed by the case manager and the call was due by 10:30 a.m. the next day. Somehow someone saw it and we were able to make the call, but they continued to deny it. The family and the case manager were told that the family could file a fast appeal, but they said, we will approve SNF level of care, but only if the family requests it within the next 24 hours. They did not mention that we could do an expedited provider appeal, but we filed one. That payer called to request an AOR form, and it was a Spanish-speaking patient. And 2 days later, on Easter Sunday, they called my cell to say the appeal for acute rehab had overturned the denial. The patient stayed an extra 5 nights after the rehab went for authorization. Case study 2, also a Medicare Advantage plan, this time from 2023. This was a lung transplant patient, trached and vent. English was not their first language. Authorization for LTAC was denied. P2P call, the attending was not aware of different levels of rehab and was very proud of herself for getting the patient authorized for acute level of rehab, but she was trached and vented, and acute rehab will not wean the vent. So we filed an expedited provider appeal for LTAC. The payer sent the case to a third-party reviewer who supported the denial, but the transplant team did not want her to go to the acute level of rehab, and no other level of rehab was appropriate for this patient. She stayed in our acute facility to rehab. We weaned her off the ventilator and the trach was decannulated. She eventually went home with services. However, the family changed the insurance from Medicare Advantage back to traditional Medicare in the event she needed further hospitalizations. She stayed 24 extra nights with us after the rehab went for auth. And the last case study, this is a commercial plan from 2024. A patient in their 60s with myasthenia gravis had a 2-week admission. PT, OT, and the physicians recommended acute rehab, but she was denied for acute rehab. Family were told they could do a family fast appeal. The hospital was in code capacity and the case manager felt pressured to discharge that day. The patient was told she could either go to SNF or go home with services while the family appeal was in process. So she chose to go home with services. She didn't want to go back to another SNF. However, she was readmitted 6 days later to the ICU, requiring intubation, and had an additional 20-night stay before she was then discharged to acute rehab. So we have to think. I can't say for sure that she wouldn't have had a second admission if we had denied and got her into the correct level of care the first time, but appealing may reduce readmissions. Over to you, June.
Hi, Joanne, and June, this is Jean O'Leary. I've been monitoring your questions and answers, and I've been myself fascinated by what you've had to say, working in the field myself. So without further ado, I'd like to just go through some of the questions.
So Jean, I'm going to be on the question.
All right, June.
Hey.
Elizabeth asks, is the enrollment period only required when you go from Medicare, traditional Medicare, to an Advantage plan? And then if you go from an Advantage plan to traditional Medicare, the enrollment period is not in place.
Okay, so I'm so glad that that question was asked, because I just really want to clarify that. What the literature says really clearly, and the CMS guidelines, is that a patient can only move out of an MA plan to traditional Medicare during the enrollment period. It states that really clearly, and there is an enrollment period just for MA plans.
Right.
But yeah, but the thing was saying is that, and so that's it. So that's what CMS is saying, is that it only can happen during that enrollment period. But what I'm saying, and other case managers, like, I don't know, you too, Jean, because when we talked, you know, and talked about interventions, that's one of the ones you brought up right away. You said we can always, you know, discuss with the patient and the family about switching their insurance to traditional Medicare.
Right.
Am I answering that question or not? Because it is flat out, that assigned open enrollment period. That's it.
So your patient, the first, the lady that got you all inspired,
Yes,
who needed to go to LTAC, she disenrolled from a Medicare plan, Medicare Advantage plan, and was effective with her traditional Medicare the first of the following month.
right. So it happened simultaneously.
So
But on that case, we actually did a value transfer, like we talked to the hospital about covering a couple of days. And so she left the hospital about 3 days before on a value transfer. And then right on the first, like May 1st, boom, she was on traditional Medicare.
And those of you that have never worked in the MGB system and don't know what a value transfer is, occasionally when I was the director at Spalding, MGH would incentivize Spalding to take the patient by paying us up front while we worked out the authorization issues. And then in that system, they call it a value transfer.
Right.
I thought it was great when I was at Spalding. But anyway.
It is great, but so hospitals, I mean, that is an option for hospitals or any facility, you know, to think about, okay, what is the advantage of opening that bed? You know, because, you know, basically with the DRG payer, you know, from the beginning of case management, we used to say is, you know, open the bed to fill the bed. So if you have a patient coming in to fill that bed, and financially it may be an advantage. The other thing is patient satisfaction for that system.
Right.
Yeah.
good quality outcomes is what you're saying.
Yeah, so it's a trade-off.
The throughput is there, because you're always on, divert or whatever they call it in this decade. But, and the patient is happier to get moving on the project, shall we say.
That's right. And they get better, you have a husband so desperate like this one, that you meet that, you meet that family member's needs. And
So
you're really operating the best of, needs for the patient. So at MGB and in the hospitals, many of them have what's called the complex care team, which is, we had a presentation on that in the fall, with CMSNE, and that's a great asset if, because it does help to move patients quicker.
mhm.
Yeah.
Just to circle back to Elizabeth's question, when a patient goes from an Advantage plan to traditional Medicare, they do not need to do it within the enrollment period.
That's what she's saying.
She's asking.
Yeah, so I'm not really sure that, to be honest.
Okay,
But common sense tells me, yeah. So, I mean, so what I'm saying is this, is that case managers, as well as myself and, Joanne in our project, is that we were able to accomplish the transfer outside of the enrollment period. Okay.
right.
And we did, how we did it is we called Medicare, and then the family member or the patient had to call Medicare themselves to make the change. So that,
Mhm.
and I'm just looking in the chat, it says May 1st is not open enrollment. Exactly. That's what we're saying, that there's an opportunity. And part of our project is that we believe that, we were going to overcome every barrier that came up. But there was always a solution. It may not be immediately in our experience, but we were going to search it out and we were going to find it. And one way or another, most of the
Right.
time we did.
Well, and to Elizabeth's point in the chat, mostly people will go from Medicare Advantage back to traditional Medicare to get the freedom that they desire.
Correct.
It's going from traditional Medicare to Medicare Advantage, unless, for instance, they suddenly go on an expensive medication and they're going to get reimbursed. There's very little of the second direction. So
Right.
I think to answer the question, if you're going to opt out of an Advantage program and go back to traditional Medicare, the experience at MGB is that you can do it anytime.
Mm.
If you're going to go the other way, it's during the enrollment period. Actually, I thought that the enrollment period, January to March, was if you wanted to go from Medicare Advantage to Medicare Advantage. And the other enrollment period being October to December, if you wanted to go into a Medicare Advantage from traditional Medicare. So
Yeah, maybe we can look into that and then
hope that
send an
makes
update to
sense.
everybody. Yeah.
I hope that makes sense.
Yeah, it made sense to me. I hope it did. You can put something in the chat if it hasn't.
Right. An anonymous person indicates that Medicare Advantage plans, sometimes the case manager needs to help the patient and family connect with the managed care plan and the medical director at the managed care plan. Sometimes it's the case manager that doesn't do an official peer-to-peer, but does reach out. And that's a great method. Another anonymous comment, I do not like managed care plans at all. Please speak to the concerns with changing a patient from Medicare Advantage to fee-for-service. I think we've done that,
Yeah.
hopefully.
Yep. Hope so.
Keeping patients until the 1st of next month waiting for fee-for-service is not sustainable in the current capacity climate at most places and significantly can contribute to delay days. The way that MGB solved it was with the value transfer, in lieu of adding to the patient's length of stay.
Yeah.
If the patient is in a Medicare Advantage plan, they would not have a Medigap plan. So by switching them from Medicare Advantage to fee-for-service, this would have a financial implication to patients on co-pays for hospital days in their benefit period. How is this reviewed with the patient family? My understanding is that the Medicare Advantage plan could become their secondary because they had coverage under the Medicare Advantage plan to
Mhm.
begin with. That's most people, retirees, of which I am one, fortunately, that if I was to opt out of my Medicare Advantage plan, I could take my Tufts with me.
Mhm.
Be my supplement to traditional Medicare,
Yeah, it would be a different rate though, wouldn't it?
wouldn't it? Yes,
It would be a different rate because a supplement,
absolutely.
you don't pay as much.
You don't, and you don't get as much,
You don't
actually.
get as much, right? But you get your your co-pays covered
Yeah,
with
the
some. I mean, you have to
explanation,
be careful picking it.
right, right.
Right.
What discussion is had about the financial implications that will impact patients when changed to Part D, potential change to copay for drugs, et cetera? For example, some people pick a particular Medicare Advantage plan because it pays for Eliquis or other high-cost meds that they
Mhm.
afford monthly. Who is discussing the implications the change of fee-for-service will have on the patient after the immediate need of post-acute care transfer out of the acute care setting occurs? And I myself talk to my patients and families about all the implications. And I would, I'm not part of the presentation, so I'm going to turn that to June. Would you discuss the implications of potentially the Medicare supplement, the
Right.
Part D?
So in the cases that I was involved in, with Joanne, we would look at, look at the whole case, the financial, situation. Joanne, did really in-depth patient assessment. She knew the situation of each patient and family, and if she didn't, she would get that information. So we would basically in our own way look at what the implications would be financially, what the risks were, and those were discussed with the patient or the family or both, and then to help them to make that decision. So we wouldn't leave out any cost. I mean, we would, talk about each of the payments that was expected and if they needed a D, so that they would be making a wise decision.
Right, and
And we've
educated.
never heard
Right,
any repercussions. The other
right.
thing is, like Joanne talked about, is that she reached out to finance. And in my experience, well, I worked with Joanne, and in past other institutions, I worked really closely with finance, always checking, double checking everything to get the whole perspective, because it is complicated. I mean, that's part of the time consuming that's going. So there is a kind of chat that's going on. One of the attendees asked Dr. Hertz might clarify the options for changing Medicare plans. And then Dr. Hertz said, I have thought it only occurs in open enrollment. Because you know what? We talked with Dr. Hertz about this. I think it was on an ACMA chat. And I knew that's what, his thought. Never heard of it till today of an exception being given. And if a switch from MA traditional, you don't guarantee access to the supplement. So right, absolutely. You may face additional cost. And that is discussed. So it's just really what your priorities are and what the greater need is. What the greater need
Right.
is it that you need to have your drugs paid, or you need to, be fully rehabilitated?
And
And so
thank
it's
you.
a trade-off.
Yeah,
So it's
thanks,
not
Dr. Holt.
easy. It's not a simple decision.
Yeah,
It's a big decision.
there are, Christine shares, there are some specific circumstances that
Mm,
allow someone to swap out of a Medicare C outside of open enrollment, but they have to meet the criteria. Not
right,
everyone qualifies, and another participant talked about a special enrollment
right.
period. And I think that we need to let the group know what the special enrollment period
Yeah,
policy.
they're going to have to go into it in depth, because the thing that's absolutely correct. So really, I hope everybody's following the course of the conversation, because that's exactly true. There are special open enrollment or criteria that enables patients to do that. Dr. Hirsch just gave us the 1-800 Medicare number. I mean, that's what I did with the patient that we used as the first case study. And I called and, directly got the information. So that's what we recommend in the, and so that's what needs to be researched is the special enrollment circumstances or to
Well, I'm
call
gonna do
Medicare
that.
yourself. Yeah.
I have my Medicare and You
I
2000.
know it's not in there, Jean. It's not in there. You
Okay,
could look now,
let's
but
look at
we
the,
talked one night and I went into my Medicare and You. And
yeah,
it does say that there's two special enrollment periods. And it does require special criteria. See if you find it. I didn't find it.
qualifying life event. If you join
Yes,
the Medicare Advantage plan, you must keep it for the calendar year starting the date your coverage begins. However, in certain situations, like if you move or you lose other insurance coverage, you may be able to join, switch, or drop a Medicare Advantage plan during a special enrollment period. Okay, so I'm looking at the enrollment periods. When you first become eligible for Medicare, it's called the initial enrollment period when you can make changes to your Medicare Advantage plan. The general enrollment period for Medicare Advantage plans is January 1 to March 31st.
right.
And the open enrollment period where everybody can do everything is October 15th to December 7th.
So
So,
I think what that patient might have been, I mean, I'm the one that made that call to Medicare and got the action and we took it and, it happened. So it could have been that she was out of state.
right,
It may have been that. And the thing about, there's a certain number of days that you're out of state and actually your address can change to the
that's right.
facility where you're so that was my one guess, but I don't know because it was 3 years ago
Mhm.
and it happened. And let me tell you, so in my career, I worked at 5 different hospitals as a director of case management, and I did it all through my career.
Mhm.
But I never did it alone. I would, check with finance, and of course, you have to get your patient and family to agree because they're the ones that have to make the call. So I hope
Right.
that's clarified. And Dr. Rich was so nice to put the 1-800 Medicare, and I think that's the way to go. And Jean read us Medicare and You. So we are getting close to,
I need to give you a 3-minute warning there, or give us, because
yeah,
I'm talking more than you are, June.
right.
If we know that Medicare Advantage cannot deny post-acute care, then shouldn't we put the pressure back on the commercial payers through contracting instead of changing patients' insurance status? Great idea.
Yeah,
Does
you
this
can
apply,
invite them.
does this apply to acute rehab denials when the Medicare A plan will pay for SNF? Yes, it does. We saw that. And Teresa from Encompass writes, as a post-acute provider, what do you suggest we do to encourage case managers to proceed to an appeal, even though it may increase the acute length of stay? We find patients going to a lower level of care, although likely not appropriate, and increases readmission rates just to manage acute care length of stay.
Right. And don't you feel like we discussed that that's the risk if you don't appeal and your patient doesn't receive the care that they need at that time? And if they are a Medicare beneficiary, then they're not receiving their rights. If they're sent to a lower level of care and don't reach full functionality and then get readmitted and then they're complicated, the hospital's dinged, the facilities might be deemed, it's like a no-win. So
Mhm.
asking the payer to do that is a great question. And maybe if you do it once and it doesn't work, you just keep asking it until maybe you have a breakthrough. What Joanne was saying is absolutely true, that since the final rule, 2024, the payers have become very resistant, and things that worked in the past, like reading the Medicare rules to the payer or sending it in an appeal letter, used to work 100%. And now they actually get angry. They actually get angry.
Can you guys hear me? This is
Yeah, go
Ron.
ahead.
Yes,
I
Yeah.
just want to add one thing about this whole discussion that I think is really important. If you think about your hospitals, you are a short-term acute care hospital. An
right,
LTAC is a long-term acute care hospital. So technically, if you read the regulations, an LTAC and a regular hospital are the same level of care. If
right,
a patient needs an LTAC, you think your argument must not should not be that it's a Medicare benefit. It should be that the LTAC is a specialized hospital that can provide the care that we can't provide. I like to say they can wean the unweanable. They can
right.
heal the unhealable wound. So when you talk to an MA plan, make sure your argument is that just like if I was a community hospital sending someone to Mass General, they're a tertiary care. They do things we can't do. Your argument is the LTAC is going to get this patient off the vent. We tried everything we could, that we couldn't do it. Now we need their specialty care.
Not a short-term problem. It's a
Yeah.
longer-term project, if you will.
Right,
Great
right.
suggestion, Dr. Hirsch.
Thank you, Dr. Hirsch.
Sure.
Another case manager says she's never been able to have somebody change from an Advantage plan to traditional unless they're in a special enrollment period. And it also seems that each plan has different special enrollment periods.
So
Which-
we are kind of saying that. We're
Mhm.
saying basically that you can only change during the enrollment period, but there may be exceptions. And, you know,
It's worth it to try.
yeah, if you're able to try, I mean, maybe even like Joanne and I, proactively, we saw patients that could be at risk for denial. We
Mhm.
proactively spoke to them about it and this option, and they would decline it. Then you're done because it's their decision.
Last but not least, thanks for sharing the artificial intelligence component with United. Lately, we are receiving a lot of inpatient denials. 8 to
Right.
9 are overturned on peer-to-peer, and the ones we still support are sent to appeals. This is becoming a burden for our physician advisor. And just for next year's conference, how do people manage a case manager managing this intense level of service while managing a caseload of up to 15 patients in an acute
Exactly.
hospital? Just want to lay that on the table.
A good
Um,
point. We'll write it down.
Any other, last, but I'm going to do last call. Thank you so much for sticking with us on a Saturday through 1:30. Thankfully, the snow hasn't started yet and the sun is still out, so we need to get out there. But I was going to turn it back to June to wrap us up this afternoon, and thank you so much for being here. This is, I've been a case manager in a hospital for a long time, 20, 25, 30 years in through there. And this organization has really helped me move myself ahead. So I wish you the same.